Okay, now it's going. Human immunodeficiency virus, HIV disease by Maria and Melissa. Maria's going to be starting off the presentation. Okay.
Hi, everybody. So, predisposing risk factors for HIV in the U.S. are primarily contracting the infection, mostly related to contracting it by having unprotected sex, having multiple sexual partners, sharing needles or other IV equipment with an HIV positive individual. Primarily, this happens through male in the U.S. through male-to-male sexual contacts, including men having homosexual contacts and men having bisexual contacts with both men and women. Also through injection drug use by sharing needles or other IV equipment, and also by heterosexual contact with an HIV positive individual. Other risk factors, at least in the US, they aren't as common. Mother-to-child transmission, that is also known as vertical transmission, during pregnancy, labor and delivery, and through breastfeeding from an HIV positive mother, and also other risk group which are very rare in the US, are through blood transfusions and people who suffer from hemophilia who require blood transfusions.
All right, so the etiology for the virus is that oh, sorry, Maria, could you mute me? Okay, thank you. So it's a retrovirus, which means that it injects its DNA into the host cell. In other words, it hijacks the cell that it uses as a host. The timeline from the CDC thinks that it might even have started back in the 1800s. It came from a simian immunodeficiency virus. People used to hunt chimps, and then they got it through the blood of the chimps in Africa, and spread from Africa to the United States in the late 1970s. And it wasn't until 1981 that doctors in LA found that many young men homosexual men were dying from pneumocystis carinii pneumonia, which is not typically something that people would get unless they're immunocompromised. And then the virus was isolated in 1984. And in 1985 was when the CDC implemented universal precautions, which we still use today. The pathophysiology and disease process, it's a little bit complicated, but we're going to focus on the CD4 T helper cells, which is what really will classify if somebody's gone from HIV to AIDS classification. So as Maria mentioned, HIV you get from blood, semen, vaginal fluids, or breast milk. And on the HIV virus, there's a receptor called the GP120 that attaches to the CD4 receptor sites on T helper cells. And when it's able to attach to the receptor cell, it's able to inject itself into the cell, and it uses the enzymes within its capsid, transcriptase, viral RNA, and integrase, to hijack the DNA of the cell and inject its own DNA into the cell. And so the cell will produce proteins for the virus and replicate the virus within its own cell. So once the virus proteins have been made by the host, the new viruses within the cell lyse the cell, and sometimes if the proteins for the virus is found on the outside of the cell, it undergoes apoptosis from our own immunity attacking the cell. Anyway, the cell is lysed and dies, and that's why after somebody has had HIV over a number of years, the doctor can check the CD4 T helper cell load, and if they have less than 200 cells, then it's obvious that the patient now has AIDS, and that opens the patient up to having opportunistic infections because they have no immunity to protect itself from everyday bacteria, fungi, and other viruses. Some of the clinical signs and symptoms that somebody with HIV will have is that they will have fatigue, fever, muscle aches, headaches, but at the same time, you have to look at it and think, do they have another virus? Did they have the flu? Are they tired? Is there stress in their life? Some other differential diagnosis that you could go through would be the possibility of mono, maybe hepatitis, and you'd have to look for other opportunistic infections as well. So as you're testing this patient to see what's going on with them, it's interesting to know that if somebody has gotten a blood transfusion and you think perhaps they would have gotten HIV through a blood transfusion, that's the quickest way to get HIV is within 4 to 7 weeks. You'll test positive for viral HIV antibodies, and sexual transmission could take years to form antibodies. So somebody could be infected and it may not actually show a high enough viral load or show antibodies in their bloodstream for over a year potentially, depending on if the virus is latent or not. And here's a graph for for the early symptoms of HIV. The fatigue, nausea, vomiting, sore throat, swollen lymph glands, fever, chills, headaches is just something for you guys to look over that are possibility for HIV. But as you can see, it could be a lot of different things that we have to rule out. So clinical signs and symptoms as well. Like I said, people may not have antibodies even though they're infected, depending on how much their viral load is and if the virus is latent in their blood or not. And then the late signs for HIV would be AIDS, a low CD4 count less than 200. And it's interesting to know that infants that are infected through childbirth, they develop symptoms quickly around 6 months of age. They have failure to thrive. They can have microcephaly. And Maria's going to go over that a little bit more, I think, because in the United States, we don't have a lot of positive cases of children with HIV because of the treatment that we can give them. And without treatment, babies typically don't live past 3 years old. So if it's a child with HIV, you have to watch for failure to thrive and failure to meet developmental milestones, and you want to measure their head circumference because they're at risk for brain atrophy and microcephaly. And you need to watch that they have a high risk for encephalopathy. Some of the diagnostic tests that we can use are the ELISA tests. It's for antibody and antigen testing. There's the IFA, which is for antibody testing, and it's also confirms for ELISA, but they also do the Western blot. It's also used as a confirmation if somebody has a positive ELISA test. The NAT, which shows viral load, it's more sensitive. And then PCR is the most sensitive. It detects viral RNA, and it can be shown days or weeks after exposure. And then obviously you want to check their CD4 count if somebody has HIV to see how long they've had it and if they're immunocompromised now. And then we're going to go back to Maria.
So, advanced practice nurse management of HIV positive individuals. Current guidelines recommend starting antiretroviral therapy, ART, on all individuals infected with HIV, regardless of CD4 cell count. The criteria, fairly new. Before CD4 cell counts needed to reach certain criteria to be initiated on ART therapy. But now the new guidelines recommend starting ART on all individuals affected with HIV. It doesn't matter how low their CDC for cell count is, or how high, because the criteria is everybody needs to be started on ART. So ART suppresses the viral load, helps maintain high CD4 cell count levels, and prevents the progression of HIV infection into AIDS, and thus it prolongs the survival of HIV positive individuals. And continued and sustained viral suppression through ART improves the immune system and increases the quality of life, allowing patients to live a normal, nearly normal life, comparable to that of a non-infected person. So back in the day, HIV diagnosis was a death sentence, but at least here in the U.S., that's no longer the case. You receive ART treatment, ART therapy, and you can live a normal life, and the life expectancy is comparable to a person not infected with HIV. So patient education should include ART does not cure HIV. Okay, the treatment needs to be continued indefinitely, no gaps in medication administration to sustain the ongoing viral suppression. Sorry, adherence to treatment is key to success of the treatment. So that's part of the education to patients that you're going to be taking ART for the rest of your life. Okay, we don't want gaps in the medication, because otherwise the viral load will start rising again. So for that reason, providers should assess patients' barriers to accessing care on the first medical encounter and at every subsequent visit. You want to make sure that the patient is able to continue with the treatment without any gaps, and that there are no barriers to that. Part of the treatment also, part of the counseling and the education includes educating the patient on how HIV is transmitted to others. It's a concept called U equals U, which means undetectable is the same as untransmittable. And for that, you need to maintain HIV levels, the copies in the blood, to less than 200 copies per milliliter of blood, and that reduces significantly the transmission to HIV negative sexual partners. So the patients need to be educated that they need the treatment, and the treatment, the concept of U equals U means that if you are able to maintain the viral load less than 200, actually you cannot infect other people with HIV through sexual contact. So ART should be continued when trying to conceive as well and while pregnant. So like we touched before, the infants are at the higher risk of contracting HIV while being birthed through the birthing canal, where they are exposed to the vaginal fluids and the cervical fluids and the blood of the mother, and that's when they get infected. Also, through breast milk, HIV virus has been found in the colostrum and also milk. So here in the U.S., it's recommended that an HIV positive mother do have ART treatment through the whole pregnancy, and then vaginal delivery is discouraged. So C-section is preferred, so that the like I told before, the infant is not exposed through the birthing canal, and then breastfeeding is also discouraged. So here in the U.S., no problem. If you don't have money to buy formula, you have all these programs, WEEK and other programs with the formula. During the time of delivery, if they are not going to go through a C-section, achieving a viral load suppression of less than 50 copies per milliliter of blood around delivery also reduces the risk of perinatal HIV transmission from 20 to 30% down to 0.1 to 0.5. So it reduces it significantly. So providers should work with the patients to tailor an HIV regimen specific to the patient's needs, including the need to do drug sensitivity testing, results of drug resistance testing, so that they know exactly which HIV medication would be appropriate to treat their specific HIV strand. Also tolerating side effects of HIV meds. All retrovirals do have side effects, and how the patients tolerate them. Also, you are going to consider, the provider should consider drug interactions with other medications if they have other comorbidities, what meds they're on, and they need actually to tailor the treatment that they're not going to, not have drug interactions with other meds that the patient might be taking. Also, preference of mode of administration. So, like I told before, these pills, the treatment should be taken daily, pills, but now, fairly recently, there are also shots with antiretrovirals, and the shots are given monthly or bi-monthly, every 2 months, versus the once-a-day pills or combinations of pills with comparable results. So they are as effective as the daily pill regimen. And also some pills, so that patients don't become pill fatigued. Some HIV medications are combined, 2 or 3 medications in just one pill. And of course, patient insurance coverage here in the US. If you don't have insurance that would cover the HIV medication, you would get it for free. But still, you have to meet some criteria for the shot, for example, the shot mode, the injectable mode. And some insurances, maybe they would cover the pills, but not if you have insurance, but not the newest injectable form. So you also want to know the patient's insurance, if they have one, and what it covers. Antiretroviral therapy, ART, there's more than 30 HIV drugs approved by the Food and Drug Administration to treat HIV. So again, ART is a combination of different HIV meds tailored to the patient's needs. That's called the HIV regimen. And HIV regimens usually include 3 retroviral drugs from at least 2 different HIV drug classes. So also part of the antiretroviral therapy, although it's not for already infected individuals, CDC guidelines recommends that ART can be used and should be used as a preventative measure against contracting HIV. Those 2 regimens are called PrEP, which is pre-exposure prophylaxis, and PEP, which is post-exposure prophylaxis. So PrEP is ongoing ART, is a regimen of ongoing ART retroviral therapy for individuals who are at a very high risk of becoming infected through continuous exposures. They are still not infected, but antiretroviral treatment is recommended so that they don't become infected through continued exposures. And PEP is a post-exposure prophylaxis treatment. It's only in case of an emergency after an exposure. It's considered an emergency treatment after an exposure, and treatment should be started within 72 hours after the exposure. And this individual, the exposed individual, is going to be treated for 28 days in a row with antiretrovirals. So antiretrovirals are grouped in 7 drug classes according to their mode of action. So we have the non-nucleoside reverse transcriptase inhibitors. They block HIV enzyme, the reverse transcriptase, and prevent the virus from duplicating. Then you have the nucleoside reverse transcriptase inhibitors. They act similarly. They block the HIV enzyme, the same enzyme, the reverse transcriptase, and that the virus actually used to convert its own RNA into DNA, into viral DNA. Then we have the protease inhibitors. They block HIV enzyme, protease, preventing immature HIV viruses from becoming mature and being able to infect the host's CD4 cell. Then we have the fusion inhibitors. They block HIV from fusing with the host's CD4 cell's membrane and entering the cell, hijacking the cell, like Melissa said. Then we have the CCR5 antagonists. They block the R5 co-receptor on the CD40 lymphocyte cells, preventing HIV from entering the cell. Integrase strand transfer inhibitors, they block HIV enzyme. Again, the integrase enzyme preventing HIV replication. And the last one is the post-attachment inhibitors. They bind to host CD4 cells receptors, blocking HIV from attaching again and entering the cell.
Okay. So now we're going to go into the HIV case study. The question 1 goes over the initial history for the patient. It's a 32-year-old female with 5-day history of fever, dyspnea, productive cough, right-sided pleuritic, chest pain, and pneumonia 2 times over the past 3 years. They're on oral contraceptives only and no known allergies. What else do you think we could ask patients about the history of present illness and past medical history? The answer would be that we could ask about any other systemic signs and symptoms, fever, chills, nausea, vomiting, and the headache. Do they have a history of smoking? Ask about the diagnosis for the past episodes of pneumonia. And she said that she was hospitalized. Any other lung or heart diseases that they may have that contributes to this. Any other diagnosis or any other ongoing health issues that the patient might have. And question 2, additional information and history that we have is that she denies chills, vomiting, headache, or rashes. She's told that her last pneumonia was the usual kind, treated effectively with antibiotics. She has not smoked in 10 years, no history of lung disease, heart disease, or hospitalizations. A long history of yeast infections with an abnormal benign PAP, and admits that health has not been good lately with fatigue and has lost 7 pounds over the past 6 months. So what do you think about her history concerns you, and what else would you like to ask her now? I'll pause for this. We believe that some concerns that we have are the yeast infection and then with the PAP, and abnormal but benign PAP results from the past. She says that her health has not been good lately and she's lost weight. So we want to know, maybe has she had night sweats? Has she been exposed to TB or any other virus disease? Was she ever tested for TB? Did she have a PPD test? What's her job? Was she exposed to toxins? What's her lifestyle like? Does she do drugs? Does she have unprotected sex? You know, those kind of questions that we should ask. So question 3, some additional information in history is that she does have occasional night sweats and has mild anorexia for the past few months. Obviously, she lost 7 pounds. Denies any recent travel, no contact with anybody with any unusual infections or TB. Her PPD last was checked was negative, and she's had 4 sexual partners and occasional unprotected sex, and has no children. She's an accountant and doesn't think that she's been exposed to toxins. So on our examination, you can see she's thin, she looks ill, she has a productive cough, temperature is 39 Celsius, respiratory rates elevated 25, blood pressure 110/70. She has some seborrhea around the nose, cheeks, scalp. She's pearl, alert and oriented ×4. Fundi without lesions. Pharynx has thick, cheesy exudate on soft palate and tongue. Cervical adenopathy, thyroid non-palpable, lungs with dullness, percussion with tactile fremitus, inspiratory crackles, and agophony over right lower lobe. Her cardiac rhythm's normal. No masses in her abdomen. no edema, pulse is full, and she has erythema and mild excoriate of the perineum, thick white vaginal discharge, no masses, and we redid the pap smear. So what do you think of this history and her exam findings? Uh, we believe that there's a high suspicion for an HIV infection. She's had multiple sexual partners, unprotected sex. She obviously has a yeast infection. She has cervical adenopathy. She's got the signs and symptoms of pneumonia. She gets night sweats, rash, and the weight loss. So what tests would we obtain? So we would do the ELISA test to see if she has HIV, do the chest x-ray to confirm the pneumonia, do a PPD to rule out TB, do the sputum culture for the pneumonia. We could check her for, different STDs. You could do viral panels, serologies for hepatitis, do the vaginal smear for the yeast infection, and oral smear, check her CBC, and check her O2 stats, and do blood cultures. And I'm going to go on to Maria. Did you want to do the lab results?
So, lab results, HIV ELISA positive, white blood count 9,000, 90%, PMNs, platelets 190,000, CMP normal, chest x-ray, right lower lobe infiltrate with lobar pneumonia. Sputum culture was positive for gram-positive numerose PMNs and gram-positive diplococci plus S pneumonia. BC times 2 negative, oxygen saturation is 96%, PPD negative, hepatitis serology negative, oral vaginal smear positive for yeast, pap smear the results were inflammation and mild dysplasia without carcinoma. So question 5, how would you interpret these laboratory results and what would you do next? So the answer, the patient is HIV positive. The ELISA or ELISA test was positive. She has confirmed pneumonia. Sputum gram-positive results. The sputum positive identified as pneumonia. Elevated PMS is a sign of infection. PPD negative, so TB was ruled out. Or smear KOH positive for yeast infections. So what would we do next? She needs antibiotics for the pneumonia. We need to treat the yeast infection. And we're going to do a Western blot test to confirm the HIV diagnosis by the ELISA test. So hospital course, it says the patient is responding to the antibiotics and the hydration, and the Western blot test result came back positive. So question 6, what additional laboratory tests would you order now? We will order HIV RNA PCR test to determine the viral loads, the HIV viral load levels that she has. CD4, we will order a CD4 cell count blood test to establish her immune system status. Lipid to rule out dyslipidemia, know her baseline at the start of treatment. Antiretroviral treatment can increase HDL, decrease HDL, which is a good cholesterol, and increase LDL levels. So you want to know the baseline of this patient, or if she has some compromise, already in some areas. Serologies to detect opportunistic infections like syphilis, toxoplasmosis, hepatitis A, B, C, cytomegalovirus, and varicella zoster. So additional laboratory results, the HIV RNA PCR result came back with 25,000 copies. That's is a moderate viral load. A high viral load is considered more than 100,000 copies. A low viral load for an HIV positive person at diagnosis less than 10,000 copies. So the CD4 count was 400. So the CD4 count, like I said, it's a reflection of the immune system status. So a normal value would be between 500 and 600. So she's just below 500, 400. So between 250 and 500 is criteria for HIV. Below 200 fits the criteria to be diagnosed with AIDS. So lipid profile was normal. Serologies came all back negative. So question 7, how should this patient be managed? So we would do a drug. She would be started on ART as soon as possible, but we would need to do also drug resistance testing to know the genotypic and phenotypic testing to identify which HIV drugs will not be effective against the patient's specific HIV strain. Start the patient on ART as soon as possible. Current guidelines, like I said before, of care indicate to start ART regardless of the CD4 cell count. And of course, we should have to receive HIV counseling and education about and ongoing testing to monitor her viral load and response to treatment. CD4 cell count need to be tested and retested, and also drug toxicity side effects of the medication, and of course she will need to have a lot of education as well if she has a partner, an HIV negative partner, all the things that we have discussed before. So all of that is part of the education, and so the patient needs to be aware how other people can contract it from them, and need to own it, right? They need to be responsible and use protective barrier methods, and also maintain that viral load below 200 to become to achieve U equals U, and detectable and transmittable.
Okay.
Yeah, our references. Do you have any questions?
Thank you.
Thank you. Any questions, you can post them. Thank you very much. Bye-bye.